Right. Good morning. We're now at the University of Colorado Anschutz Medical Campus in the Department of Otolaryngology, Head and Neck Surgery. We're hosting today Professor Mahmood Bhutta from the Brighton and Sussex Medical School ENT Surgery. He's an inaugural chair there, and he was kind enough to drop by to give this lecture for us today. Thank you, Mood. I first met Mood in 2015, and back then he was still a resident, already a rising star internationally. At that time, he has already collected more than 2,000 families for genome-wide association and family-based association studies from Oxford, as well as done quite a good number of animal models for otitis media. But now he has expanded his portfolio. Today, he'll be talking about community-based care and hospital-based care in low-resource settings for chronic otitis media, and we're really pleased to host him today. Thank you, Mood.
Thanks very much. And obviously it's a small group, so feel free to interrupt. So as Reggie has kindly already suggested, you know, I've been dabbling in all sorts of different things. I started in genetics and now have really moved to the chronically discharging, another form of otitis media. Is very common in low resource settings where you have a hole in the eardrum and pus coming out intermittently or even continuously. So I'm going to talk to you about that, but I also do some work for those of you who might be interested in public health agenda, in sustainability in healthcare, in terms of labor rights and environmental harms caused by healthcare, and various other things. But I'm going to try and stay on topic today. So thank you for having me. So I'm going to start by just sort of explaining the problem, and I understand I've got a mixed audience. So I'm going to try and meet those needs for a varied audience. The problem, I think, is useful to look back in history and understand that this sort of problem seemed to exist in history in high resource countries as well. So this is a paper by someone called Sir Charles Ballance, who was actually a pioneer of otology, writing in 1899 about disease in London. So chronic suppurations, you know, pus coming out, exist in such quantities to be counted by the thousands if only the outpatient, the hospitals of London are included. So back in Victorian England, this was a very, very common problem. And in fact, if you look through other, as I have done, if you look through other examples, there are even people writing of, well, remember being a child in and around the hospital. And when you were a child, you used to think, oh, all of these children are in this hospital with otitis media. This was possibly before we had antibiotics as well. And the child would remember, wake up in the morning and see if all the children are still alive. Because one of the things that otitis media causes, rarely, but still significant, is that the infection can spread into the brain and cause death. So children used to die of this, and I have no doubt that in low resource settings, they still do. Autopsy reports, which I've looked at from 19th century England, show that 1 in 200 people died from ear disease. So this is also a serious risk, not only to your health, but also to mortality. And again, it's not documented in low resource settings, but I'm sure that we have something comparable still going on. So chronic suppurative otitis media, that is a disease where there's a hole in the eardrum. Sorry, I probably should have put that slide up first because perhaps not all of us understand what this means. It's a hole in the eardrum. Exactly what causes it is debated, and we could talk at length about that, but it's probably related to us getting an infection. So the most common bacterial infection in childhood, as many in this room will know, is an ear infection. In high resource countries, that usually heals and we don't get any problems. What causes that hole in the eardrum is not really well understood. It may be a bad eardrum infection, bad infection of the middle ear that doesn't allow the eardrum to heal. It may be repeated low-level bacterial presence that causes that perforation. And once that perforation is there, you're at risk of developing ear disease. So it is a disease associated with socioeconomic deprivation, both in the US and the UK. We find it seems to be more prevalent in low resource settings within a country, but also we find that it's a very prevalent disease in low resource countries. So a higher prevalence also is found in rural or remote areas in these populations. So the typical level of chronic suppurative otitis media, a hole in the eardrum in countries such as the UK, have been shown to be about 1 in 200. So not that common, but still a significant disorder that we will deal with as surgeons to repair the eardrum. But in some of the low resource settings, it's quite typical to have 4 or 5% prevalence and sometimes even much higher. So this is a classic example of the inverse care law, because where we have the greatest amount of disease, and this is a huge disease, we have a relative lack of resources or ability to deal with it. And I'll come on to evidence that as we move on. So this is a classic inverse care law. So the epidemiology, the last estimates are around 250 million people around the world live with a hole in their eardrum. Actually, we're remodeling and we think it's probably going to be nearer to 300 million. That's a paper that we're just publishing very soon. So as I've said, typical prevalence is it's a much more disorder of low and middle income countries. And associated with that, 2/3 of people have disabling hearing loss. And remember, this is children as much as adults. So the prevalence in children is as high as it is in adults. And so that affects education. It also affects for adults employability. 2/3 have also had ear discharge, and actually very few people have documented this. How often is that ear discharge? But from a study we've done in Bangladesh, which I'll come on to show you later, more than 2/3 of people had ear discharge more than 3 times a year, or some had it continuously. So imagine that you've got pus coming out of your ear all the time or very frequently. And I can tell you that that is stigmatizing to people. It smells and it's difficult for people to live with. They self-stigmatize as well as receive stigma from those around them. Who wants to marry the girl with a smelly ear? It is unpleasant for people. So it risks also death because it can erode the bone around the ear, and that can lead to infection into the brain because the brain is living just above what we call the tympanic space, really, the middle ear cleft where all of this exists. So in fact, the most common cause of a brain abscess in the temporal region and that side of the head is from ear disease. And it can also spread in other places as well outside, go down into the neck and so on. So lower quality of life, that's been shown, and stigma. I've actually just written a paper in the Lancet that documents all of these. So I present to you some statistics, but behind all of this, we must remember this is a human story. So these are this is some quote from some work we did in Cambodia, looking at the experiences of people living with chronic suppurative otitis media, and they describe it as pretty bad. You know, the pus came out, they try to hide it, it's stigmatizing. They don't want people to know because it's embarrassing. And so this is a difficult condition for people to live with. And the hearing loss is also not to be underestimated. I remember when I was last in Cambodia, we were operating and performing a tympanoplasty on a gentleman. And I said, well, what do you want out of this operation? He said, you know what? I can't work with other people. I want to be able to work in an office. My entire life, I have worked on fishing boats because it's so hard to communicate with people. And that's all he wanted, was to have the opportunity to do something different. It's often called a hidden disability because we don't see it. Of course, the ear is hidden down deep inside. The hearing loss is not evident to us in the same way that visual loss is. So this is often called a hidden disability. And people can also face stigma from people in society because we're so focused on communication individually from person to person that when someone doesn't hear, we may think it's perhaps a bit funny, or perhaps we think those people lack intelligence. Of course, that's not true. That is our own stigma, but that stigma transmits to other people. And when you've got discharging ear, there's additional stigma associated with that. Here's the data on that inverse care law that I was mentioning. Here's the limited data we have. And as I say, we're actually remodeling this with a bit more accuracy, I have to say, than this paper. What we find is that the highest prevalence of chronic suppurative otitis media is in areas such as sub-Saharan Africa, but particularly Southeast Asia. I think these data need updating, as I say. But wherever you find poverty, you find a high prevalence of chronic suppurative otitis media. And here's some data from 2012. In fact, we need to update this as well because it's some newer data on the number of ENT specialists. Now, I'm not so stupid to think that ENT specialists are the only way to deal with what is a massive public health problem. Nevertheless, the ENT specialists represent the leadership, if you like, for ear and hearing care in many of these countries. And you can see there is an absolute lack of specialists in these countries. So between 0 and 0.88 per million in many of these countries in sub-Saharan Africa. And sometimes there are countries that have no ENT specialists at all. And it's a failure of us to actually recognize this as a major global health problem from the ENT community and argue for it. Many, many more people, perhaps up to 20 times more people, live with disabling hearing loss than live with disabling visual loss. Yet everybody is aware around the world of the visual loss because it's been well documented, and we see that as a human suffering, but we don't see hearing loss in quite the same scale. So what are the models that we can use to try and tackle this? One option is surgical care. And I still believe that surgical care is probably the gold standard for treatment, because if you've got a discharging hole in your eardrum, we don't have any good evidence that it will heal by itself if it's been present for a long, long time. And so a tympanoplasty, which is a repair of the eardrum, is probably still, on current evidence, the best standard for treatment. And that requires surgical repair. The problem is if you haven't got a lot of ENT resource, of course, the traditional model is to provide visiting services. We can fly surgeons out to sort of help with these sorts of problems. But I do have some concerns about that approach. So tympanoplasty and possibly mastoidectomy, so that's drilling into the bone here, is the gold standard treatment. So there's another type of disorder that I should have mentioned where the skin, so the hole in the eardrum isn't just a hole, but some of the skin around the edge of the hole also grows inward. That's something called a cholesteatoma. And if you get that, that actually starts to erode into the bone, and that's a higher risk of developing disease inside the brain. So there you need a mastoidectomy. You need to drill open the hole here and excise this. But the problem is these are difficult operations. I've done hundreds of them, and I still struggle sometimes with some of these operations. It's complex. The anatomy is difficult. There's a need for a microscope and a drill and microscopic ear instruments, things that are not readily available in low resource settings. And even in the US, from a survey that was done, it took an average of 4.5 years for residents in the US ENT program to feel somewhat confident going into an ear. And I'd say that's just the beginning, because I still struggle, as I say, with some of these ears. It's a difficult operation. The approach that's traditionally used by the majority is this humanitarian surgical otology, and I do have some reservations about this. So a survey that was undertaken 5 years ago of more than 300 US ENT surgeons involved in global health outreach programs related to ENT revealed that 35% of them had visited a hospital only once, and that 93% went for no longer than 2 weeks. So I understand humanitarian care. It is perhaps best for things like disasters, such as conflict zones and war zones, or natural disasters, such as earthquakes. But if we want to talk about global health and global surgical care, I think we need different models where we are developing local capacity, because, of course, this can treat a few, but it cannot treat the many. And there is no way, despite what we think, that going out for 2 weeks is going to train a surgeon to be able to do a very complex procedure. Some would argue you shouldn't go out at all, and you should provide more support, all that funding, to those people. Nevertheless, it has value if it's the start of a long-term collaboration. So I was lucky enough to have the opportunity, when I finished my training in 2016 in the UK, to go out to Cambodia. Someone had told me about that they had an opportunity in Cambodia where they wanted to train some surgeons. And so this was a different model of trying to develop local capacity in otological care. So to give you some background, Cambodia is ranked 138th in the UN Development Programme Human Development Index. It's now a lower middle income country. It is rising up, but have no doubt that that doesn't mean that the whole country is rich, because we see a lot of income divide. In some of the cities, such as Phnom Penh, the capital where I was based, there is some wealth. But even within that city, and certainly when you go to the rural parts, people are living in poverty. So around a quarter live in poverty, especially in rural communities, but loss of just 30 cents a day would lead to about 40% of people living in poverty. So these people are really on the breadline, and you see that when you go there. So this was, I could give you the background history to this. Unfortunately, it was related to bombing during the Vietnam War, where there was bombing. The amount of bombs that were also spread into Cambodia, unfortunately, led to a lot of death of people. That led to the rise of communism within that country, which didn't really exist. And Pol Pot came into power, who created a genocide of his own population. 1/3 of the population of Cambodia was killed or died of starvation in a period of 5 years. Horrendous for that country. So it's still recovering from that, but fantastic, friendly people is what I would say. So this is me out there. I spent 5 months in the country trying to teach these individuals and my colleagues to perform mastoidectomy. In fact, someone had gone out before me for a year and had started to set up, and he taught them tympanoplasty, so the repair of the eardrum, and I was teaching them mastoidectomy, which is actually approach to drill out this cholesteatoma, quite complex, difficult surgery. Just by chance, actually, these happened to be that the whole team was female, other than myself, of course. And that actually became a cause celeb for actually female empowerment. Davi, who's standing next to me there on the right, is the head of the ENT department. She'd worked in the local ENT hospital, who apparently could do everything, but I saw their mastoidectomies, and I promise you, they did not know what they were doing, but there was too many egos there. But she'd been told she couldn't possibly be an ENT surgeon because women had hands that were too weak to do this sort of thing. So this is the sort of unfortunate issue that we started with. So I spent 5 months there, and I have to say, this team was fantastic. Just to give you some context of some of the diseases that we deal with, I don't know if you see this often here, but this is a mastoid fistula where that cholesteatoma that's eroded through the bone has eroded through the bone. Unfortunately, in this case, it's come out through the skin rather than up into the brain. So this was a patient that I was involved with. He was a 15-year-old boy. He'd actually had discharge coming out the side of his head for the last 2 years and finally heard about this unit that could deal with this. So it's quite severe disease that you see. In fact, quite often, I think we found 1 in 10 cases, we had large sections of dura, the lining of the brain, completely exposed when we went in. That's quite rare to see in this country. We do see it from time to time. This is probably the worst case I dealt with in my entire career. This gentleman had come to us with a 40-year history of a discharging ear, but a 20-year history of something called facial paralysis. So the facial nerve runs through the middle ear, and this guy had a facial paralysis partial for 20 years. He'd been to see the traditional healer who told him to put some salted beef on the side of his face and perhaps it would all get better, but I think he actually needed his massive cholesteatoma excised from his ear. So yeah, this is my record. He actually came when he had an abscess in his neck from his cholesteatoma. So I actually drained that first and then took him to theatre. And I'm not a particularly slow surgeon, but that one took me 9 hours because his cholesteatoma had completely eroded his entire ear canal. It eroded in almost his entire inner ear. It eroded into his parotid gland, that's the saliva gland here, and it eroded down into his neck. I don't know how he was alive, to be honest. He's very lucky it didn't go up into his brain. So I had to remove cholesteatoma from around his facial nerve, completely 360 degrees. I've never seen that, with the facial nerve just completely hanging by itself, surrounded by cholesteatoma. This is what you end up with. It's not that impressive at the end because it's a hole about that big. And you think, why did you spend 9 hours? But there's a lot of clockwork in there. And it was only after I finished operating and he got better, and luckily his facial nerve function returned to what it was before the operation, that he told me he happened to be the local chief of police. So I was quite glad that that operation went well, because people do go missing in Cambodia, and I'm still here today. So what are the results of this actual approach? So we wanted to measure their outcomes, okay? And often people, when they do global health, don't measure the outcomes. It's quite important for us to do. So tympanoplasty, which is a repair of the eardrum, in most hands, and I'd say in my hands as well, has about 80 to 90% success rate. And that's what I tell my patients. So what did they do? So what we measured is they'd had a year of training with tympanoplasty by my former colleague, and then they had a period of about a year when nobody was there, and they were doing tympanoplasties by themselves. So we measured their success rate for the first year after operating completely solo by themselves. Nobody else is around. And we found they had a closure rate of 88% at their first post-op visit. Now, there may be some late failures, but I'll be honest, with patients in low-resource countries, they'll come back once and then they won't come again because they say, my ear is fine. That's pretty good. That is comparable to anything that we get in the UK. And I can promise you, these ears are really bad, really often very scarred, been discharging for a long time, often almost the entire eardrum is missing. When we measured their hearing results, and hearing is always difficult after an operation like this because if the eardrum's scarred, the hearing doesn't normally repair, but it may do. And most patients just want a dry ear. They want the pus to stop coming out. But we still found that it was an improvement in hearing in quite a lot of the patients, and often with functional hearing. So I think if we measure functional hearing, can you actually hear day-to-day conversations? Around about 40% of these patients returned to that state. What about mastoidectomy? So this operation that I taught them, where you actually go into the skull and you remove the cholesteatoma, this is shortly after they completed their training. And it's difficult to actually measure results from mastoidectomy. But what I decided was to measure something called the dry ear rate. So after you do a mastoidectomy, quite a lot of patients are at risk of getting continuing discharge because the lining and the structure of the ear has been changed, and actually a good mastoid cavity should not discharge. So as well as removing all the cholesteatoma, you should have a dry ear. And when we looked at that at 1 year, their results were comparable to foreign surgeons, basically myself. So again, very proud that they've got comparable results dealing with some of the most difficult disease that you see. So that all sounds great. And I have to say, I think that's one of the most useful things I've done. I've trained 2 ear surgeons in Cambodia. They've now trained someone else. They keep saying, hey, can you come back? And I say, I can, but only to learn from you, because you guys do far worse ear disease than I deal with. And I know people who've been out there and gone, oh, wow, I can't teach these guys anything. I need to learn from them. So I'm very proud of that. However, I'm cognizant that this is still just the tip of an iceberg. So we're dealing with disease, and this is where we've decided to look at where our patients are coming from. And so I was based in Phnom Penh, the capital, just because obviously that's a convenient location for transport and infrastructure. But when we looked across Cambodia, these are all the provinces, where are people coming from? And unsurprisingly, the vast majority are coming from Phnom Penh. And maybe that's because it's got a rich population density. But I can't imagine that in Stung Treng and Mondulkiri up in the top right that there is no disease. In fact, that is the poorest part of Cambodia. So you'd predict that there is a lot of disease up there. But at the $5 to get on the coach to come to Phnom Penh is too much for people. They cannot afford it. So we're still, arguably, not dealing with the vast burden of disease. So what else? One approach is bringing surgery to the community. So let's not operate in a big center. Can we bring surgery out to the community? And this has already been done to some extent in some countries. So for example, I know in Nepal, they do outreaches. They'll go out with a tent and a full microscope and full generator and do some camps out in some remote areas. I've worked in Nepal before as well. And that's a good model. But I thought, is there an even more frugal model that we can do that actually makes things very, very approachable? So I was asked a couple of years ago, because I seem to be someone who's interested in this area, if I could help out also in Bangladesh. So I don't know if you know about some of the problems with the Rohingya people of Bangladesh. Well, no, sorry, they are of Myanmar. So this is in Bangladesh. It's an area called Kutupalong. It's the largest refugee camp in the world. There's probably at least 1 million people living in this refugee camp, and they have faced real genocide, effectively, from Myanmar, a crackdown. They are a Muslim minority in Myanmar and have, frankly, faced prejudice for a long, long time. But then around 7 years ago, with a change in structure and the power struggles that are still ongoing in Myanmar, with the war that's going on inside there, they faced genocide. This cannot be described in any other way. The military came in and said that they have no right. So they changed the constitution that if you did not have papers, you were no longer valid to be in the country. This is generations of people that have lived in this country. They were then classified as not belonging to Myanmar. It's quite surprising for a Buddhist country that they can still be subject to genocide. I'm afraid these sorts of human behaviors, as we're seeing around the world, seem to be universal. Doesn't matter what belief system you supposedly follow. Their houses were burnt down. People were shot dead. I know of children that were thrown alive onto burning fires. This makes me sad to be human, but these people understandably fled, and they fled over the border to this long-established refugee camp where they knew that some of their predecessors had gone there, and now they faced no choice but to go there. But Bangladesh does not say that they can come into the country. I think they show sympathy towards them, but Bangladesh is also a very poor country, struggling with the health needs of its own population. So they've created a refugee camp, but people cannot leave that refugee camp without permission, and they don't have any regular health services. So when I was asked to help out, I didn't want to experiment on these people in any way, but actually I thought this is what requires a locally led surgical service, or to explore that opportunity. So as they fled over the border, this is the sorts of conditions that people live in. They don't have any sort of, if you like, concrete walls or brick walls, because this has to be temporary accommodation. The idea is that they will go back to Myanmar at some point and be repatriated. Whether or not that's going to happen, I don't know. There are 3 generations of families now living in these camps, because people have been there for a long, long time, over 50 years. You can imagine the mental health issues are quite severe, with lots of post-traumatic stress disorder, with lots of ideas and thoughts of suicide, but people keep going because they have families. So this is the conditions they live in. We were told that there was probably some ear disease there, and that's why we wanted to go. There's lots of respiratory tract infections because of extreme overcrowding, because of poverty, because of malnutrition. But they have limited access to health services. There's UN, United Nations Human Refugee Group is out there, and they've got a big office trying to help. And they actually built a hospital in Ukiah, which is just outside of this camp, where they can actually bring some of these refugees out to this hospital. So they had recognized there was lots of ear disease. They just said that they knew about it, and they'd actually said, we want to set up ENT, but they didn't really have the resource there to do so. So they didn't have regular anesthetists or anesthetic equipment. I think from time to time, they can get an anesthetist to come there. So we have no general anesthesia regularly available. They had some ENT specialists, but I can tell you they are not qualified to do surgery, and they're still very, very junior. So they're trying to tackle very difficult disease with very little background training, shall we say. So here was an opportunity to trial a different approach to tympanoplasty, which is basically, let's do surgery on a public health model, which is treat as many as you can with as little resource as you can. So this was a local anesthetic tympanoplasty. So you can inject local anesthetic, anesthetize the eardrum, and see if you can repair it that way. Most people in high resource settings will give a general anesthetic, put people to sleep, because it can be quite difficult. You've got lots of scarring, you want to clear all that away, but that's just not available for most of the world. And we also did something called a push-through graft. So normally I would lift up the eardrum and put the graft underneath. Here, we can just put this graft, which is a bit of tissue taken from around here. It's something called the tragus, the cartilage here. We remove something and we just push it through and see if that works. Now, I was somewhat skeptical about this. So let's be clear that I'm not going in and saying this is all going to be a panacea, but this is what we set up. So when inside the hospital, it's brand new. You can see nice clean white walls. It won't be like that now, I'm afraid, but we were one of the first groups to go in there. And what we did was we took endoscopes. So rather than a microscope, you can actually carry that with you. It connects to, in fact, we're trying to create one that just connects to a laptop. So you have an endoscope, sticks to a laptop. You can actually take your equipment anywhere you want to go. You don't need anything. You just need a bed, really, for someone to lie down on. So local anesthetic tympanoplasty. But it's challenging. This disease is, as you'd expect, severe. These people have had discharging ears for a long, long time. So the picture at the top right there, yeah, perhaps you're not used to looking, but that should be an eardrum, and the eardrum is basically completely missing. What you're seeing there is through the eardrum onto the medial wall of the middle ear. So a huge hole. Those are much more difficult to treat. Picture on the right here, that's a discharging ear. We saw quite a lot of those. About 1 in 10 who turned up had active discharge. Now, ideally, you want to settle that discharge down, treat it, come back when it's dry. You don't have that luxury when you're there for 2 or 3 days. So we just had to operate on those as well. Just clean them out, wash it out with some iodine, and off you go. We also had, you see the bottom right there, that's bottom left there. That's also a big hole in the eardrum. But I don't know if you can appreciate that little thing there, the white nubbin at the top there, that's the malleus, the first bone of hearing. It's eroded, but it's also stuck. There's huge amounts of scar tissue inside that ear. So that's also a real challenge, particularly under local anesthetic, to try and deal with that. So I had no doubt that we were optimistic with what we were going to do. And actually we consented everybody to say, I think at best 50% success rate. And they were happy to go with that. So we ended up operating on 26 patients over 2 days, myself and another surgeon. And we planned to operate only on adults, but someone actually came to us with their 14-year-old child and said, please, can you help? Because the ear discharge is so terrible, it's really affecting her. And so we did operate on a 14-year-old. She did very well under local anesthetic. That was not my intention, but she did very well. We found the majority did come for follow-up, and we had to obviously remove them from the camp to be able to find them and come up. And what we found is, in fact, half of them had successful closure, and we were quite happy with that. We had no major complications, and every patient was happy to go for it. And quite a lot of them, we improved their hearing. And we thought, maybe this is not great. And perhaps realistically, we need to perhaps choose which patients we're going to operate on. But this was still reasonably successful. And what's the greatest marker of success? We now have, I'm going back to Bangladesh in a few months, a huge queue of people who say, that was great. I heard that you can have something done. So queues of people, despite the 50% success rate, to say, please, I want to have a go. But still not good enough. So we decided, okay, you're saying that there's a lot of ear disease. Let's actually do a survey. So we decided to do a prevalence survey of chronic suppurative otitis media in this population. We did a cluster epidemiological sampling, so just sampling people at random in one of the what's called the camps. There's this million people are split into multiple different camps. We went into one called Camp 4, randomly sampled people consecutively with a power. We calculated we needed 290 sample size, and we found one of the highest rates ever reported of chronic suppurative otitis media. So 14.5%, so about 1 in 7 people live with a hole in their eardrum. And 4 to 5% is from both ears, and it was quite high also in children, so about 8% in children. And I didn't put it in here, but as I mentioned before, about 2/3 of them had ear discharge at least 3 or 4 times a year, and quite a 1 in 5 of them had continuous ear discharge, the ear just constantly draining pus. Most of them had been to see other health specialists. We found that as well. They'd often had drops, they'd had some traditional healing. Most of the time, it just hadn't worked, or if it worked, it'd only be temporary. So that again gives evidence that ultimately we do want tympanoplasty. But in a camp of 1 million, if we take that as a true prevalence, 141,000 in that camp alone have a perforation. There is no way I can be quick, but I can't operate on 141,000 in my lifetime. So this again is not enough to deal with a major public health burden. So what else? What about the idea of trying to deliver care in the community? And so there's been this model that's been suggested, which is using community health workers. So community health workers, for those of you not aware of what happens in a lot of low resource settings, is a different cadre of workers. Rather than having doctors and specialists, we say, hey, well, let's take people from the community who are trained to actually help with healthcare. They're often, most of them are educated at sort of school level, so they're literate, but not always the case, I'm afraid. And many of them have no real background in health, but they are trained in health. But the problem is they often have lots of different other things that they need to do. They're not just focused on ear and hearing care. It'll be things like maternal health, and often it's a guiding role. But the World Health Organization has put forward this as a major sort of theme of what to do. And I work with the World Health Organization. In fact, I'm one of their leads for developing training resources in an honorary capacity, because the World Health Organization, by the way, has no money. So I've been working with them, and we've been working on community health worker programs, but I'm still somewhat pessimistic about it. And I'll come and show you why. So what did we do? There's a manual that's been developed for community health workers. This already existed. I was involved heavily in the revision of this manual, which was released in March 2023. And what I introduced actually was moving from multiple choice questions at the end of a training program to an OSCE based. Presumably you guys have OSCEs here. Yeah, okay. So inductive structured clinical examinations, where you actually measure that the people can diagnose disease and they can manage the disease. So actually, have they learnt the skills? Because I'm much more interested in that than whether you know the anatomy of the tympanic membrane. Actually, that doesn't matter. Can you manage the disease, diagnose it, and deal with it in community? So we field tested this training program in Uganda and Fiji and Zambia, and through that, actually, I've made a lot of contacts. What were the outcomes? First of all, we did a systematic review of the evidence of community health workers in ear and hearing care, and we found there's very limited literature. Community health workers can perform automated audiological screening, so screening for hearing loss, but there's no evidence we could find that they can actually diagnose what's going on. And I think we have a somewhat naive view that we think, oh, you can look in the ear and you can see what's going on. I can tell you, most medical students have no idea what's going on. Many of the residents, I'm afraid, still are not entirely sure what's going on. And I have to tell you, I'm not always sure what's going on. I take them to a microscope and have a good look and make a judgment call. So the idea that you can have non-specialist workers making these diagnoses out in the community, I think comes with a little bit of caveat. And I'll come on to show you that. And as I mentioned, most of the literature just said, hey, we trained some people and we gave them an MCQ, multiple choice question, before and after the training. And look, they were trained. Not so sure. So I tried to actually evaluate a community health worker, and this was a PhD I supervised, where we trained some health workers in Uganda, in a village in a remote part of Uganda, naive community health workers who were very interested in it. We gave them 6 months, first of all, a training program, and then supported them with ongoing liaison about the cases they were seeing. And I can tell you very quickly, it was clear that there was a huge amount of disease. They said, oh yeah, we know lots of people with discharging ears. And what does it mean if you've got this hole at the back of your head? I'm like, okay, we know a few people with that as well. That's a cholesteatoma that's eroded through. So what we found at the end of that 6-month period is we reevaluated the whole program. We say, hey, let's see what they saw going out to the community. And what did they say? Well, 98% of the referrals to specialist care were deemed appropriate. So we looked at the cases they brought in, and they were quite rightly saying, hey, that needs to see a specialist 98% of the time. That's pretty good. But getting the diagnosis, only 39%. So they can recognize that there's a problem, but they can't necessarily diagnose what it is. And the critic in me would say, doesn't the patient already know that they've got a problem? And if we just set up a service for specialists, maybe that's a better model. Rather than thinking that we train these community health workers, patients know they've got a problem with their ear, come and see a specialist and miss out that inexpert in between. I don't know, but that's questions that need to be asked. What about if we use technology to assist with diagnosis? And there's lots of people trying to do AI and technologies to diagnose things. At this stage, we were looking at, actually, you can take a photo of the eardrum, okay, using a number of different resources. This is an otoscope to look in the ear that fixes to a phone, and you can send it to a specialist, or you can have a look yourself. The truth is, people say, oh, you're going to take all these pictures and send it to a specialist. I don't know about you, but I'm not normally sitting around twiddling my thumb waiting for thousands of images to come in that I've got the time to review and tell you what's going on. So that's the problem. You want to send it to a specialist. That specialist is busy. So can it actually be that they're diagnosing correctly, and we actually just review a few images and say, yes, you did get that right? So what we did was an assessment of 138 presented to CSC is the hospital where I work, a charity hospital in Cambodia, where I was working before. And of those 138 ears, we found 22 of them had chronic suppurative otitis media. So we compared three different outputs. A telediagnosis, so that is someone, myself in this case, actually looking at all those pictures and saying, I think this is what's wrong, with a very short history as well of what's going on. Nurse diagnosis, so the nurse effectively represented the non-specialist worker. And actually, these nurses had been working in the department for several years, so they'd seen lots of disease. And in some ways, they were more qualified than you might find in a community health worker working in a community. Or a prediction model, which is actually, you just take the patient's history and you say, hey, what's going on? The gold standard was on-site diagnosis by Davi, the head of ENT, the specialist that I've trained. So that's our gold standard. And we looked at sensitivity and specificity of the results. Yes, no, chronic suppurative otitis media, hole in the eardrum, or not. Telediagnosis, that's me. I agreed with the on-site specialist with high sensitivity and high specificity. Pretty much, we agreed what was going on and that there was a hole in the eardrum. Non-specialist diagnosis, yeah, they got it right when they got it right. That's the specificity of the test. The sensitivity, picking up all of those who had a hole in the eardrum, quite low. Only a third of cases were they correct that there was CSOM. So is that a good model? And these are nurses who've been dealing with this for a long, long time. What about prediction model diagnosis? If you just ask the patient, have you got ear disease? Have you got a discharging ear? Or have you got some pain in your ear from time to time? And if they said yes to that, actually, you got a much better sensitivity and specificity than a non-specialist. So this is why I question the community health worker model. Actually, the patient gives you the diagnosis most of the time. You still need to have a look, but perhaps you're better off just seeing the specialist straight away who can deal with the problem. So we've got this problem where we've got specialists who can deal with the ultimate care, but we're never going to have enough of those to deal with this huge burden of disease. We've got this interim of the community health workers, and I have some caveats about it, as I've already said. And maybe we need to think of a different model and remove that central structure and talk about community-based solutions. We're talking about self-care. Can patients actually manage this disease in some way themselves? And that's not really been looked at. And that's what I'm now really focused on. And in fact, I'd recently got a big health grant, a global health grant to develop that work. The two main symptoms that people get from this disease are ear discharge, otorrhea, and hearing loss. As I mentioned, 2/3 have disabling hearing loss. So otorrhea, topical antibiotics are the gold standard. So we give antibiotics, usually things like ciprofloxacin, ofloxacin, into the ear, but they are not readily available. I can promise you there is no pharmacy out in the villages of Africa that gives you topical ciprofloxacin that's ready to go. Where you can get it, you might need to go to the local town. It may be falsified. There are false medicines that are out there. So you're just not going to get access to it. Plus the cost of it. People can't afford these. They are struggling to even get clean water. In addition, most countries for antibiotics require a prescription. So you need to interact with the health system, and there are costs and difficulties associated with that. But iodine is widely available, an antiseptic compound, and anecdotally has been used in many different countries. I've used it myself. Wash out ears with iodine, and anecdotally, we know that it works. And that's readily available. It doesn't require a prescription, and as far as we can tell, is not particularly toxic to the ear. Could it be self-administered? And this is what I'm interested in. If you just tell patients how to put in iodine, can they just manage the ear discharge themselves? Hey, maybe the eardrum doesn't heal, but actually if they say, oh, the discharge is better and I can manage it when it comes, I can just deal with it myself. Hearing loss. At the moment, we do have hearing aids as an alternative to surgery, and even if you do surgery, it doesn't always work. So hearing aids is one option. However, air conduction hearing aids are problematic. So the traditional hearing aid that you might say, for two reasons, well, for several reasons actually. It's available on last measures to only 3 or 4% of the population in low and middle income countries who would benefit from it. And we could argue about why hearing aids are not widely available. The cost is one of the major things, but I can tell you it is a perverse financial market for hearing aids. So you may be interested that we in the NHS in the UK think we pay too much, but we will pay about $200 for a set of hearing aids fully fitted. In this country, I think you can pay up to $6,000 for exactly the same hearing aid. So, you know, socialized medicine, as you call it, has many advantages. We buy in bulk and we will not pay those fees. I have no doubt that it probably costs $5 to $10 to make a hearing aid, but which hearing aid company wants to sell these hearing aids to Africa at that sort of price when they can sell them for much more here? What would that say about what you guys are paying here? What else? You need batteries, which is bizarre. Why have not all hearing aids moved to rechargeable? I'm certainly pushing for the NHS to say batteries are old. We should not be having batteries that you need to change, because unsurprisingly, those cell batteries are not widely available and too costly in Africa. So you give a hearing aid, they use it for about 2 weeks and they say the batteries run out. And inappropriate also for this particular disorder, because in the presence of ear discharge, if you put something in your ear and block it off, it can often make it worse. So an alternative is something called a bone conduction aid. What that is we actually send sound through the bone of the skull. That directly stimulates the cochlea, so it doesn't actually matter what's going on in there. And you don't actually need to program it potentially, because if the inner ear hearing is okay, it's just a problem with the eardrum or the bones of hearing, you bypass all of that and you say the inner ear is okay, you can hear. Traditional bone conduction aids are implanted. I do them as well, and they cost in the UK, they cost about $4,000. I don't know what they cost here. So still require surgical care, but you can provide bone conduction aids that are not implanted. So first of all, what's the evidence for treatment of otolaryngology and chronic suppurative otitis media? So I was actually the clinical ENT lead. We did a suite of 7 Cochrane reviews. I don't know if you know about Cochrane. It's a mechanism to do meta-analysis of a number of trials. And what we did from a huge amount of work is we found that topical antibiotics indeed are the current best treatment. But for antiseptics, for iodine, there was only one trial which had about 40 patients, and that was it. So that's a real missing gap in the literature. And we also had no evidence of any long-term outcomes from any of these treatments. Does the eardrum heal, or are we just temporarily dealing with a problem? So part of the funding I've got is actually do a randomized control trial of self-administered topical iodine. And that will include about 250 patients, which is sufficient power. It will be self-administered. We are there just to observe rather than to intervene. So the idea is, can patients themselves do this? And that will be taking part in 2 villages in Zambia and 2 in Malawi, and in collaboration with the University of Zambia. So I'm very much for collaboration and research capacity development. That will be 2 PhDs in Zambia. But also, that's a spelling mistake, evidence for low-cost bone conduction. So there are these sports headphones, maybe you've seen them. People runners and cyclists wearing these headphones. And actually, those are bone conductors. They're sending sound to the cochlea. And when we saw that, and I saw someone else, one of my colleagues, who started to use these for children with something called glue ear, which is not a hole in the eardrum, but they get fluid in the eardrum, they can't hear. They showed on small trials quite a lot of benefit for kids. And I thought, well, hang on, can't we just use that for the kids and the adults with discharging ear? Could we repurpose these? And although we've got some commercially available, actually, we've got a company that's making a low-cost, high-quality version, which is currently around $60, but I think we can get it down to $5 or $10 ultimately when mass-produced. So it becomes in the realms of affordability. We've just completed a pilot study in Malawi with my PhD student, Tom Hampton. We're writing up the results from that, but I can tell you the initial results are phenomenal. Kids can hear. The school teachers tell us this is fantastic. The kid is back in the class. They're doing really, really well. So part of the funding I've got is also do a large scale trial. Here in Malawi, the pilot trial, we were actually targeting children. We evaluated them. We took school children who had the problem. What we're doing now in Malawi and Zambia is a straight to community trial. No healthcare worker involved. We don't even test your hearing. If you're discharging ear and some hearing loss, have a go. And then we'll measure afterwards what the outcomes are. Because my ultimate solution is if this works, you can just bite yourself down the shop. You don't need any medical intervention, because of course we don't have that available. That's in collaboration with the Liverpool Malawi Wellcome Trust Centre in Malawi. So I'd like to finish there, still work in progress, but we're getting there, and acknowledge a huge number of people that have supported all of the work that I'm speaking about today. And thank you for your time.
Switch to speed review, so I can see you with the recording. All right, any questions from the audience?
That was really great overview. So I'm curious for the camp where you saw the super high prevalence rate. How much effort has gone into these community health care workers helping with other aspects of just basic sanitation and that kind of thing? Maybe that's where those resources are better directed, which is coming before ultimately they develop these problems later.
Sure. So yeah, in my paper in the Lancet, I said the ultimate solution is, of course, to stop the poverty. I don't have any quick wins for that one, I'm afraid. You're right. So there is work at the camps, which are within each camp. There are little centres for health, which are not proper full centres, but they'll have health staff who come in. There is posters and education about hygiene and those sorts of things. But can we deal with the overcrowding and the malnutrition? Unfortunately not. There are, should we say, some difficult political situations, because there is a feeling as well, as unfortunately you find with immigrants from anywhere, I'm afraid, of a feeling of animosity somewhat towards these people. We are poor in Bangladesh. Poor people have some issues with giving lots of food. So there's been some malnutrition, there's not enough food. It's a difficult situation. So those underlying factors of poverty, overcrowding, malnutrition definitely should be dealt with. But I don't think we're going to be able to, get rid of the disease in my lifetime. So you're absolutely right. Well, what I am doing in January is delivering some training to some of the camp health, each of the camp's leads, to train them on this, train them with the WHO manual, even though they might not get rid of the disease. At least they understand more of the disease, and they're going to train each of the staff in their community. So I think at least spreading the word, and also I think reducing the stigma, that a lot of people won't come and talk about it. If you say, hey, we recognize what this problem is, it's not necessarily a hygiene problem, which is what some people think, and they don't want to tell anyone about it, then I think at least we start that process for saying, hey, this is something we can try and help with. We're also just got some funding to try the bone conductors actually in the camp. So that'll be another arm of what we're trying to do. Yeah, with solar power. So thank you.
Yeah. I just wanted to introduce myself. I'm Steve Cass. I'm an otologist here.
Right.
So I appreciate everything that you've done. We treat a lot of patients here actually with tympanic membrane perforations with observation.
Yeah.
So not everyone who has a tympanic membrane perforation.
Absolutely. Yeah.
And so it seemed to me if you're in a low resource area and you need a specialist, you should be maybe focusing on those serious disorders like cholesteatoma, like you said, that are leading to massive infections and threat to life and things like that. But it seems to me also that your approach for self-care or maybe some community care for managing the episodes of otorrhea, sound really promising, I would think. We had a wonderful presentation last year because we had the OSSEO 2023 meeting here. And I don't know if you know Saeed Bamla. He's a frugal technologist.
Great.
With an interest in hearing. And he gave a wonderful presentation on how him and his graduate students had created a hearing aid that's like $1.30.
I have read about that. Yeah,
that's what it costs to make the hearing is $1.30. And it's possible. So we actually set the seed for you know, maybe having some of his graduate students work on the bone conduction idea as well.
Great.
And I mean, these people are really aggressively trying to drive the cost down, because even $1.30 to them is like too much.
Oh, yeah.
You know, they want to get it down to like 50 cents, so, I guess I encourage, maybe contact with him
Yeah.
and making that network happen. Because it might be that managing the episodes of gonorrhea with self-care and then using hearing aid, either bone conduction or air conduction at $1.50 a piece might be a good solution.
Yeah, absolutely. I think so. You're right. I'd manage many cases of perforated drum conservatively as well if they don't have ear discharge. But these guys want an operation because they're tired of their ear discharge. We had one or two who had a dry ear, and we said, "Well, it's up to you because we're probably not going to affect their ear."
I know could dry up the ear.
It could indeed. So
We use it here too.
yeah,
My final question is do you have any thoughts about the pathogenesis of these perfs? Because maybe you have 140,000 of them right now, but more are happening all the time. And so maybe you could get in front of it somehow. I mean, what's the pathogenesis? Is it happening in infancy? Is it happening, how's it happening in the beginning? 'Cause
so
maybe you can stop that trajectory.
yeah. So we don't have a lot of evidence on what's causing it, other than we know it associates with socioeconomic deprivation. So it probably is, just burden on bacterial disease. But you're right. Well, we don't have evidence, and we reviewed this. There is no evidence of whether intervening at a young age, for example, on a child that's got a perforation and dealing with that
Or an
aggressive,
infection.
or an infection,
Yeah.
dealing with that aggressively will stop the risk later on. Theoretically, of course, it makes sense. Yeah, theoretically, it makes sense. So you're right. So possibly by training more community health workers and recognizing that there is a resource available to these, we might be able to start treating those infections when they do occur earlier and prevent the long-term sequelae. But we don't know. There's also very little evidence of vaccination, whether that helps, but vaccination could also help as well. There's some trials that have been done in Australia where they have a huge burden of disease in the Aboriginal population and they recommend treating early for otitis media in childhood, but when I ask them, they don't have the evidence that actually works. But these large epidemiological scale studies are always very difficult. But
we had Peter Santa Maria here just a few weeks ago.
okay,
From Australia, and he was talking about that. And one of the interesting things that came out of the talk was one of his major interventions that helped was actually just having a swimming pool, a chlorinated swimming pool that that the kids would go into, like once a week or something, and on purpose just to get clean. And actually the chlorinated water in the ear dramatically cut down the rates of otorrhea. So it could be just like having a swimming pool.
It could be. So there's actually two bits of evidence for that, and they're contradictory. One says it makes it worse, and one says it makes it better. So I've just actually published a review in the Lancet just last month, and we looked at all the evidence, and the evidence of swimming pools was 50-50.
Yeah,
So
it was interesting.
yeah.
But it was more like just a public health intervention had this positive effect on the ear and the otorrhea rates.
Yeah, but probably getting hold of iodine is easier than installing a swimming pool, of course, in the communities.
Use a pool of iodine.
Yeah. Thank your kids in every day.
Well, thanks for coming.
No, thank you. And very happy to follow up on those contacts and ideas. Thank you.